So I'm going to take you through the entire because I think the patient selection criteria may not take completing. So I'm just covering that as well. Well, same lecture I'm going to present downstairs immediately after the things, but okay, I'll take you through that as well. So introduction, UK is a definitely an excellent treatment option for the patient with the unicondylar knee degeneration with optimal survival shape up to 20 years. So, but despite the excellent success rate with the modern implants, the unicompartmental knee replacement continue to show relatively high failure rates, revision rates, especially when compared with the total knee replacement. And that is why we have a setback in our mind that we should not offer a uni to the patient. But if you see the most failures in a uni offers in the first 5 years of the surgery, index surgery. And this is because of the basically incorrect clinical and radiological indication for the patient, selection of the patient, and second is the surgical technique. So if you choose your patient wisely for the uni, I think you are going to increase the accuracy of this process. So if you see the original criteria put for the Cousins-Scott way back in 1900s, so if you see that we could able to do only 6 to 8% of total knees for the conversion to the unis. But over the period with the development of the prostheses, the technology, with techniques, the implant designs, I think the new criteria put forward by Newfield Group or as well as the Oxford Group, I think we could able to do at almost 35% of patients, we can offer the unis for those patients. So what are those indications? Basically, as I say, it's a anteromedial osteoarthritis. And you have to just choose a AMOA only patient because you don't want a medial compartmental arthritis, but it's a AMOA, anteromedial, where the arthritis lying in the anterior part or the central part. Osteonecrosis of the femoral condyle is another rational indication for the unis. If you have a frontal deformity less than 15 degree, flexion contraction less than 15 degree, you can offer a uni to patient, but prerequisite is you should have a normal ACL, you should have a normal MCL, you should have a full thickness cartilage in another compartment or contralateral compartment, and your patellofemoral joint is with lateral grooving or a bone loss, like a erosive lateral facet arthritis is big no-no for the unis. So I say contraindication is like an inflammatory arthritis, post-osteo, and post-terminal arthritis of the knee. So if we to when I to offer UK, I think you have to do a thorough clinical examination for the patient, and what you need to see is the correctable varus. So what is a correctable varus? When your patient is standing, you see there is a varus going of the knee, and as soon as patient sit or bend the knee, the varus disappears, and it always happens because if your ACL is intact, there is no translation of the tibia over the femur, and that is why you are protecting the posterior cartilage. And as soon as you bend your knee, your femur is jumping on a natural cartilage which is retained on the posterior compartment, creating a tautness in the MCL, and that is why you get a correctable varus. And that is what extremely important when you are examining the patient. Second thing, your patient should not tell you the grasp sign, that it should able to pinpoint where exactly the pain is. You should not able to grasp the entire joint saying there is a pain. That means it's a diffuse pain, and you should restrain this patient from the unicompartmental replacement. Another, you have to check for the MCL integrity. Take you through for ACL integrity, you take a Drawer test, Lashman test. If you're pretty fine, I think your ACL is intact, your MCL is intact, and there should not be a resting pain. So, or a minimal resting pain. Patient should have a pain when patient is doing some activity, walking, climbing up and down. But when, as soon as the patient is lying down, sitting, sleeping, patient should not get a resting pain, because the resting pain is there, probably is a tricompartmental arthritis, or you have to find another source for the pain for these patients. Age is not a barrier for the unis. You can offer uni for a younger patient, for an older patient. In fact, as Sinu said, if you offer the unis in an older patient, I think it has got less morbidity, or even the rehabilitation is much less in this patient. I think it is a wise decision, or it is a good decision to offer a patient in a unis if we can able to do these patients rather than TKs. BMI again is not a contraindication. In my practice, I prefer less than 30 BMI for the unis, because most of the R patient has got osteoporosis. Okay, high obesity with a high BMI with osteoporosis is a big contraindication. But per se, if you say the BMI even 30, 40 is not a contraindication for the uni as for the Oxford Group. Anterior knee pain is again not really a good contraindication, because most of our patient has got anterior knee pain or a moderate to degenerative change in patellofemoral joint. Only lateral erosive arthritis in the lateral patellofemoral joint is a major contraindication, and you should be aware of that. So coming to the radiology, so what you should ask patient when you're seeing for this arthritic patient. I think initially whenever any kind of arthritic patient, we offer them get a AP X-ray, standing weight bearing X-ray or a true lateral X-ray. But when you're thinking of the UKR, I think you have to add some additional substrate of the patient. What we normally call as UKR profile is like you have to offer, if possible, a Rosenberg view, stress X-rays in varus and valgus, and a new model like standing scanograms and skyline merchants or sunrise view for the patellofemoral joint. See what you have to see. See, standing AP X-ray should be a very standardized X-ray. Okay, when you're doing for uni, you have to offer very standardized X-ray. And what is standardized X-ray? You see, when you're doing AP, your patella should be facing bang front. Okay, it should not be in a rotational profile. That you have to see first. Second thing, your alignment of the X-ray should be in the plane of the tibia, so in the posterior slope. So you should not have an overlapping tibia when you're reading these X-rays. So you have to instruct your X-ray technician what kind of X-ray you want, because on the rotation X-ray you cannot plan the UKR, and this is the thing which you have to master so that you don't need anything else to do for the patient for offering the unis. Second thing is lateral X-ray. You should have a lateral X-ray, true lateral X-ray, what you call as your condyle should be overlapping on each other. Okay, so this is, so again if you see the AP, you can able to find osteochondral defects kind of things in the standard AP X-ray, and these are standard AP X-ray. Sometimes what happens when you're doing a standing AP weight bearing X-ray, you could able to find some sort of cartilage over here. And these are not a good patient for the unis. But as soon as you do the Rosenberg view, you could able to see there's a bone and bone disease. So if you feel that it's a partial loss of cartilage, I always keep a habit of offering, asking for the Rosenberg view that can delineate whether we should have a full thickness cartilage loss or not. And if at all patient has a full thickness cartilage loss, you can go with a unicompartment replacement. But if it's not a full thickness cartilage loss, I think you should not offer any kind of UKR and start searching for the other source of pain in these patients. Again, lateral X-ray, what you want to see in the lateral X-ray, you want to see the wear pattern of the arthritis in the lateral X-ray. So if you get a wear pattern anteriorly or centrally, I think probably you're looking for the intact ACL, because wear pattern is not going posteriorly. If the ACL is, if your ACL is torn, what happens? There is a translation of the tibia anteriorly and the wear pattern goes behind because of the continuous translatory movement of the tibia, and wear pattern goes posteriorly, and these are the big no for the unis. So this you can delineate only on the lateral X-ray. Again, another things you have to see if the posterior osteophytes, patellofemoral joint, you can analyze then on the lateral X-ray. Another things, once you see this posterior osteophytes, or this is an anterior ancillary osteophyte, I think, see what it gives the idea that your ACL is intact, okay? But if you keep continuing this osteophytes for a long time, it tends ACL when on extension, and probably the ACL rupture happens. So that is the that also indicates there is an anteromedial disease, and it gives a telltale sign that your ACL might be intact, and you can offer a uni replacement for these patients. Stress X-rays are extremely important. You should keep a habit, instruct your radiologist how to take a X-ray, because most of the time when you're doing a stress X-ray, your femur rotates. If your technician is not pretty wise to do this, most of the time your knee either go in internal rotation or external rotation, depending on whether you're going varus or valgus. What you want to see in the varus valgus X-ray, that whether you are not collapsing the other compartment, and what is the status of the affected compartment, whether you have a bone and bone disease. Whenever you're doing valgus stress, you should able to maintain your lateral height, and that is indicating that the thickness of the cartilage in the other compartment is normal. So this is the example what I'm to see, because many times when you see the radiologically, what is the importance of long films? Because nowadays we are asking for the long films. Reason, once you see this kind of X-ray, you see that is a middle compartmental disease, and you start thinking we can offer the unicompartmental UKR. But as soon as you do the long film, see what is happening, okay? See the varus going, okay? It is beyond the limit. See, UKR is meant to fill the gap, okay? You're not going to correct the axis of the knee joint as you do in a total knee replacement. So what has happened, because even if you fill this gap, you're not still able to rectify the axis completely, and you're not going to maintain the constitutional axis, and probably this patient will remain with some sort of varus. And if the varus is going more than 3 to 4 degrees, probably this uni is going to fail. And you have to beware of these patients. So offering a uni, I think rather unis, you should offer a TKs in these kind of patients, though it is a middle compartmental disease. Coming to the patellofemoral, either Dr. Ashutosh already explained, middle patellar arthritis or a facetal arthritis or a minimal lateral facet arthritis is no contraindication for unis. But if you have a bone loss, grooving, and a subluxation and lateralization, lateral patellar facet or a translation of patella, I think you should not offer any unis for this kind of patient. You need to consider some special situations when we are offering unis, like we have a AMOA with a mucoid degeneration of ACLs, and we have a AMOA in a younger patient where the ACL has torn and have instability, and where sometimes we get a ACL tear in a middle compartment in older age. But this require technically demanding things. Basically, the new papers are coming. You can very well do the unis. Even if you have mucoid degeneration, you can go and decompress the ganglion cyst, and you can debulk the ACL, and you can still do the unis in patient. But it is technically demanding again. ACL tear with instability having a AMOA, you can do the simultaneous ACL reconstruction for the uni, but this really requires technicality, and your expertise should be at a higher level, because you have to adjust your tunnels, you have to adjust your cuts, and it requires expertise over the period. So as a beginner, one should not take this for the ACLs, but once you start doing multiple, more and more unis, I think you can offer a good results on these patients as well. And again, if you have a ACL tear in an older age group with a compartment disease, still unicompartmental remains a viable option in these patients. So just wanted to tell again some example where unis can go. You have to keep the total knee as a backup in these patients when you offer uni. Middle compartmental disease, but as soon as you do the stress test, you can see there is a additional opening of a middle compartment, which is not normal. And when you see this kind of X-rays, think that there's something going to have a surprise is when you're going to open for the unis, and you have to keep the total knees as a backup. Because if you see open, you can see this, the wear pattern is going way behind. Still, you are going to have some sort of maintenance of lateral cartilage, opening of this middle compartmental, but they are unusually opening more, and then you should be aware of those things and should not offer unis for this patient. So why we are want to choose radiologically or clinically? If you see the paper, radiological decision A to determine suitability depending upon space between femur and tibia, functionally intact ACL, full thickness lateral cartilage, functional normal MCL, acceptable patellofemoral joint. And what the paper has to say, the sensitivity and specificity of this, if you choose the radiological markers, I think sensitivity becomes 93% and specificity becomes a 96%. And even if you use this diagnostic tool or a decision aid criteria, I think the 5-year survival rate of the unis are increasing up to 99%. And this increases the accuracy of the procedure. So uni is like this, you should have a good accuracy and good precision, and if you can do that, you can hit the target properly. So this is just an example of the unis. Thank you.